The emergency room clock read 11:43 p.m. when Dr. Jennifer Walsh walked through the sliding doors for her first shift at Metropolitan General Hospital. Her scrubs were wrinkled from the long drive across 3 states, her medical bag worn from years of moving between temporary assignments. The charge nurse barely looked up from her paperwork when Jennifer approached the desk. Another temp, she probably thought. Another desperate doctor willing to work the graveyard shift for half the usual pay. What the staff at Metropolitan General didn't know was that Dr. Jennifer Walsh had just completed the most grueling medical assignment of her career. 6 months in a remote Doctors Without Borders clinic in South Sudan, where she'd performed surgery by candlelight and saved lives with equipment most American hospitals would throw away. But tonight, she was just the substitute surgeon nobody wanted to work with. Dr. Marcus Reed, the chief of surgery, emerged from the break room with coffee stains on his lab coat and exhaustion written across his face. He'd been covering emergency surgeries for 18 straight hours after 2 of his senior surgeons called in sick. When he saw Jennifer standing at the nurse's station, his expression shifted from tired relief to barely concealed skepticism. "You're the replacement from the agency," he said, not bothering to make it sound like a question. Jennifer nodded, extending her hand for a handshake that never came. Dr. Reed was already scanning her appearance, taking in the discount scrubs and the medical bag that had seen better days. "Hope you can handle basic procedures," he muttered. "We're backed up for hours, and I don't have time to babysit." The other surgical staff exchanged glances as Jennifer followed Dr. Reed down the hallway. She'd seen those looks before, in hospitals from Chicago to Phoenix. The same dismissive expressions that said she was just another temporary fill-in, someone to handle the simple cases, while the real surgeons took care of the important work. They saw desperation. In her willingness to take last-minute assignments, they did. See the steady hands that had sutured wounds while rebel gunfire echoed outside clinic walls. "Your first case is in OR 2, Dr. Reed continued, without looking back. "Routine appendectomy on a college student. Should be straightforward enough, even for someone with your background." He handed her a patient file without bothering to brief her on the case details. The dismissal was clear. "Handle this one simple surgery, stay out of the way, and collect your paycheck." Jennifer accepted the file and headed toward the surgical prep area, where she found the anesthesiologist already reviewing the patient's charts. Dr. Amanda Chen looked up as Jennifer entered, her expression polite but cautious. "You must be the temp surgeon," she said. "I'm Dr. Chen. I'll be handling anesthesia tonight." As Jennifer began her surgical prep routine, Dr. Chen watched with growing curiosity. The temp surgeon's movements were precise, economical, practiced. She scrubbed her hands with the methodical efficiency of someone who'd learned that every second could mean the difference between life and death. This wasn't the hurried preparation of a desperate fill-in doctor. This was the ritual of someone who'd performed surgery under conditions most physicians couldn't imagine. The patient, 19-year-old Marcus Thompson, was already unconscious when Jennifer entered OR 2. His appendix had ruptured hours earlier, but he'd waited until the pain became unbearable before seeking help. What should have been a routine 30-minute procedure had become a race against sepsis and systemic infection. Jennifer studied the monitors, noting the subtle signs that the other staff had missed. The patient's blood pressure was dropping faster than expected. His white blood cell count suggested the infection was spreading more aggressively. than anyone realized. This wasn't going to be the simple surgery Dr. Reed had described. "Scalpel," Jennifer said quietly, her voice carrying a calm authority that made the surgical nurse pause. There was something different about this temp surgeon, something that didn't match the desperate substitute they'd been expecting. Her first incision was perfect, clean, revealing the surgical field with minimal tissue trauma. Dr. Chen monitored the anesthesia from her position at the head of the table, but found herself watching Jennifer's technique. The temp surgeon worked with a precision that seemed almost supernatural. Every cut was deliberate, every movement calculated for maximum efficiency with minimal damage. This wasn't just competent surgery, this was artistry. The appendix was worse than the scans had indicated, severely infected, partially ruptured, with signs of peritonitis spreading throughout the abdominal cavity. Most surgeons would have called for assistance, requested a senior physician, or at minimum extended the surgery time to handle the complications carefully. Jennifer simply adjusted her approach and continued working. "Irrigation and suction," she requested, her voice steady despite the complexity of what she was facing. The surgical nurse complied, watching as Jennifer cleaned the infected tissue with movements that spoke of experience beyond what any temporary assignment should provide. She was handling a complicated case with the confidence of someone who'd seen far worse under far more challenging conditions. In the observation gallery above OR 2, Dr. Reed had stopped to check on the simple appendectomy he'd assigned to the temp surgeon. He expected to find her struggling with basic procedures, maybe needing guidance from the nursing staff. Instead, he found himself watching surgical technique that made him question everything he thought he knew about temporary physicians. The surgery that should have taken 45 minutes was being completed in 28 minutes. The patient's vitals were stabilizing despite the severity of the infection. The temp surgeon was not only handling the complications, she was resolving them with of skill that Dr. Level Reed rarely saw from his own senior staff. "Patient is stable," Jennifer announced as she began closing the incisions. "Infection has been cleared. No signs of peritonitis. Full recovery expected within 72 hours. She stepped back from the table, stripping off her surgical gloves with the same calm efficiency she'd shown throughout the procedure. Dr. Chen found herself staring at the monitors in amazement. The patient's vital signs were better than they'd been all evening. The surgery had been flawless, the technique perfect, the results better than anyone had dared hope for. Who was this temp surgeon, and where had she learned to operate with such incredible skill? As Jennifer left OR 2, she found Dr. Reed waiting in the hallway, his expression a mixture of confusion and growing respect. "That was," he began, then stopped, clearly struggling to process what he'd witnessed. Where did you learn to handle complications like that?" Jennifer met his gaze with the same calm confidence she'd shown in surgery. "Experience teaches you to adapt quickly," she said simply. "Is there another case that needs attention?" Dr. Reed checked his watch, then looked at the surgical schedule. They had 2 more emergency cases coming in, both more complex than the appendectomy she'd just completed flawlessly. Cases he'd planned to handle himself because he didn't trust a temporary surgeon with anything challenging. "There's a gallbladder removal scheduled for OR 1, he said slowly, "but it's complicated. Patient has extensive scar tissue from previous surgeries, history of complications. I was planning to take that case myself. Jennifer was already reviewing the patient file that a nurse had handed her. Laparoscopic cholecystectomy with adhesions, she said, scanning the medical history. Challenging but manageable. I can prep immediately if needed. Dr. Reed found himself nodding before he'd consciously made the decision. Something about this Temp surgeon's confidence, her obvious competence, made him willing to trust her with cases he wouldn't normally assign to temporary staff. The way she'd handled the appendectomy suggested she was capable of far more than anyone had initially assumed. As Jennifer headed toward OR1 to prep for her second surgery of the night, word was already spreading through the hospital about the temp surgeon who'd just performed what might have been the most technically perfect appendectomy the nursing staff had ever witnessed. The second surgery presented challenges that would have intimidated most experienced surgeons. 47-year-old Maria Santos lay on the operating table in OR1, her medical history reading like a catalog of surgical nightmares. 3 previous abdominal operations had left her internal cavity filled with adhesions, scar tissue that turned what should have been a routine gallbladder removal into a treacherous maze of complications. Dr. Reed observed from the gallery as Jennifer began her pre-surgical assessment. The laparoscopic approach would be nearly impossible given the extent of scar tissue, but an open procedure carried its own significant risks. Most surgeons would have spent 20 minutes discussing options with the surgical team. Jennifer simply studied the patient's scans for 90 seconds and made her decision. "We're going laparoscopic," she announced to the surgical team. Dr. Chen raised an eyebrow from her position at the anesthesia station. The scar tissue formations were extensive enough that most surgeons would automatically switch to an open approach, but something in Jennifer's voice suggested she saw a path that others had missed. The first trocar insertion required precision that bordered on the impossible. Jennifer had to navigate through layers of adhesions while avoiding damage to the bowel, liver, and major blood vessels. One wrong move would force an emergency conversion to open surgery, dramatically increasing the patient's recovery time and complication risks. Her hands moved with mechanical precision, each movement calculated to avoid the web of scar tissue that had formed over years of previous surgeries. The surgical team watched in fascination as she found pathways through the adhesions that seemed to exist only in her mind. This wasn't luck or good fortune. This was surgical navigation at its highest level. "Cautery," Jennifer requested, her voice maintaining the same steady calm she'd shown throughout both procedures. She began carefully separating adhesions, freeing the gallbladder from the scar tissue that had essentially encased it. The work was meticulous, requiring the kind of patience and skill that developed only through handling similar cases dozens of times. Dr. Reed found himself leaning forward in the observation gallery, trying to understand the technique he was witnessing. The temp surgeon was using approaches he'd never seen before, finding solutions to surgical problems that he would have considered nearly impossible to resolve laparoscopically. Where had she learned these methods? The gallbladder itself was severely inflamed, filled with stones, and adhered to surrounding tissue in ways that made removal extraordinarily difficult. Jennifer worked steadily, using electrocautery to separate the organ from the liver bed, while avoiding the hepatic artery and bile duct. One slip could result in catastrophic bleeding or bile leakage. "Clip and cut," she said, preparing to sever the cystic artery. The surgical nurse handed her the clips, watching as Jennifer placed them with mathematical precision. The artery was sealed perfectly, the gallbladder freed from its vascular connections without any signs of bleeding or complications. The extraction required threading the inflamed gallbladder through the same maze of scar tissue Jennifer had navigated during the initial approach. Most surgeons would have enlarged one of the trocar sites to make extraction easier, but she managed to remove the organ through the standard small incisions, minimizing the patient's scarring and recovery time. Irrigation complete, infection clear, Jennifer announced as she performed a final inspection of the surgical site. All bleeding controlled, no signs of bile leakage, patient stable for closure. She had completed one of the most technically challenging laparoscopic procedures the hospital had seen in months, and she'd done it in 43 minutes. Dr. Chen monitored the patient's emergence from anesthesia, noting vital signs that were remarkably stable, considering the complexity of the surgery the surgeon had not only just witnessed. The Temp complications, she'd achieved better outcomes than most senior surgeons managed with routine cases. As Jennifer completed her post-operative notes, the charge nurse approached with news that made her pause. "Dr. Walsh," she said quietly, "we just received word about an incoming trauma. Multi-vehicle accident on Highway 94. 3 critical patients, ETA 12 minutes. Dr. Reed wants to know if you're available to assist." Jennifer looked at the clock. It was approaching 2 a.m., and she'd already completed 2 complex surgeries with flawless results. Most temp surgeons would have cited fatigue, suggested bringing in additional staff, or at minimum, requested a brief break before taking on trauma cases. Instead, she simply nodded and began preparing for what promised to be the most challenging cases of her shift. The first ambulance arrived, with sirens wailing, bringing a 28-year-old construction worker who'd been trapped in his vehicle for 45 minutes. Multiple rib fractures, probable internal bleeding, and a pneumothorax that was compromising his breathing. The kind of case that required immediate surgical intervention and absolute precision under pressure. Dr. Reed met the ambulance crew at the emergency entrance, but found himself looking for the temp surgeon who'd just demonstrated surgical skills that defied explanation. He needed his best people for these trauma cases, and incredibly, that now included the substitute physician he'd dismissed as a desperate fill-in just hours earlier. Jennifer appeared at the trauma bay doors as the patient was being wheeled in, her demeanor calm despite the chaos surrounding the emergency response. She assessed the patient's condition with practiced efficiency, noting the signs that indicated immediate surgical intervention would be necessary to save his life. The patient's blood pressure was dropping rapidly, suggesting internal bleeding that wouldn't wait for extensive diagnostic procedures. His breathing was labored due to the collapsed lung, and his level of consciousness was declining steadily. This was a case where every second counted, where hesitation or uncertainty could mean the difference between life and death. OR 3 is prepped and ready, the charge nurse reported. Dr. Reed looked at Jennifer, realizing he was about to trust a temp surgeon with a trauma case that would challenge even his most experienced staff. Everything he'd witnessed over the past 3 hours suggested she was capable of handling whatever complications arose. But trauma surgery demanded skills that went beyond technical competence. It required the ability to make life and death decisions under extreme pressure, to adapt instantly when unexpected complications arose, and to maintain absolute focus while multiple crises unfolded simultaneously. These were qualities that couldn't be taught in medical school or developed through routine hospital rotations. They came from experience in situations where failure wasn't an option and backup wasn't available. As Jennifer scrubbed for her third surgery of the night, she reflected on the irony of her situation. The hospital staff still saw her as a substitute, a temporary solution to their staffing problems. They had no idea that she'd spent the last 6 months performing surgery in conditions that made tonight's cases seem routine by comparison. But in the trauma bay, surrounded by monitors and emergency equipment, Jennifer felt the familiar focus that had carried her through countless crises. The patient was coding as they wheeled him into OR 3, his vital signs deteriorating rapidly despite the emergency interventions performed by the paramedics. This was the moment that separated competent surgeons from exceptional ones. Dr. Chen was already positioning the anesthesia equipment when Jennifer entered the operating room. The patient's collapsed lung was making ventilation difficult, and his blood pressure continued dropping at an alarming rate. Most surgeons would have spent precious minutes stabilizing the patient before beginning the procedure, but Jennifer recognized the signs of internal bleeding that wouldn't wait for conventional approaches. "Emergency thoracotomy," she announced, her voice cutting through the controlled chaos of the trauma response. The surgical team exchanged glances. Emergency thoracotomies were high-risk procedures typically reserved for the most desperate situations, when conventional approaches had failed and death was imminent. But something in Jennifer's tone suggested she saw this as the optimal solution rather than a last resort. The incision had to be perfect on the first attempt. Jennifer's scalpel moved with precision that made the surgical nurses step back in amazement. She opened the chest cavity with movements that spoke of experience in situations where there was no margin for error, no opportunity for second attempts, no backup if things went wrong. Blood immediately poured from the surgical site, confirming the internal hemorrhaging that Jennifer had diagnosed from the patient's presenting symptoms. The source was a lacerated intercostal artery, hidden beneath fractured ribs and damaged lung tissue. Finding and controlling the bleeding required navigating through a maze of injured anatomy while working against time and the patient's declining vital signs. "Clamp," Jennifer said, her hands already positioning to control the bleeding vessel. The surgical nurse handed her the instrument, watching as she isolated the damaged artery, with movements that seemed almost supernatural in their precision. The bleeding stopped immediately, the patient's blood pressure beginning to stabilize for the first time since the accident. But the emergency thoracotomy had revealed additional complications that the initial scans had missed. The patient's left lung was more severely damaged than anyone had realized, with multiple lacerations that would require careful repair to prevent long-term breathing difficulties. Most trauma surgeons would have called for additional specialists, requestiacic surgery, or, at minimum, extended backup from toward the operating time to handle such complex assessed the lung repairs. Jennifer damaged and began working with techniques that left Dr. Reed speechless in the observation gallery. She was performing repairs that he'd only seen attempted by the hospital's most senior thoracic surgeons, and she was doing it with a level of skill that suggested extensive experience with similar trauma cases. The lung repairs required suturing techniques that were typically taught only in specialized fellowship programs. Jennifer worked steadily, her movements economical and precise, closing the lacerations with mathematical accuracy while preserving maximum lung function. Each suture was placed perfectly, each knot tied with the kind of precision that came from performing similar procedures under conditions most surgeons never experienced. "Chest tube placement," she announced as she prepared to address the pneumothorax that had been compromising the patient's breathing since the accident. The tube had to be positioned exactly right to drain the accumulated air and fluid while avoiding damage to surrounding structures. Too high or too low, and the patient would face ongoing respiratory complications. The chest tube SL with mechanical precision immediately into positione, relieving the pressure that had been collapsing the patient's lung. The monitors showed instant improvement in oxygen saturation and breathing mechanics. What had been a life-threatening emergency becoming a successful was trauma surgery guidance of a temp under the surgeon who wasn't supposed to possess such advanced skills. Dr. Reed found himself questioning everything he thought he knew about temporary medical staff. The woman working in OR3 wasn't just competent or even skilled. She was operating at a level that exceeded most of his permanent surgical team. Her technique was flawless, her decision-making perfect, her results better than he would have expected from surgeons with decades of experience. As Jennifer began closing the thoracotomy incision, the trauma bay alerted them to the arrival of the second accident victim, a 34-year-old woman with severe abdominal trauma, possible liver laceration, and signs of hemorrhagic shock. Another case that would require immediate surgical intervention and the kind of expertise that Jennifer had been demonstrating throughout the night. "Patient is stable," Jennifer reported as she completed the chest closure. "Full recovery expected, no complications anticipated, ready for ICU transfer." She had transformed what could have been a fatal trauma into a successful surgical outcome, and she'd done it in 57 minutes, from emergency arrival to surgical completion. The second trauma patient was already being prepped in OR1 when Jennifer finished scrubbing out of her previous case. Dr. Reed intercepted her in the hallway, his expression a mixture of amazement and growing curiosity about the temp surgeon who was redefining what he thought possible in emergency medicine. "Dr. Walsh," he said, his tone completely different from the dismissive attitude he'd shown when she first arrived. "That thoracotomy was extraordinary. Your technique, your decision-making, the speed of your work. Where exactly did you train?" Jennifer paused, considering how much of her background she was willing to reveal. "Experience comes from handling cases that challenge your limits," she said simply. "The second patient needs immediate attention. Liver trauma doesn't wait for conversations." Dr. Reed nodded, but his mind was racing with questions about the substitute surgeon who was performing at levels that defied explanation. He'd been practicing medicine for 23 years, had worked with trauma specialists from major medical centers across the country, and he'd never seen surgical skills like what he'd witnessed over the past 4 hours. The second trauma patient presented challenges that would have intimidated most emergency surgeons. The abdominal scans showed extensive internal bleeding, probable liver laceration, and signs of damage to multiple organs from the high-impact collision. This was the kind of case where surgical teams typically spent 30 minutes just planning their approach before making the first incision. Jennifer studied the scans for 90 seconds and began her surgical prep. The patient's blood pressure was critically low, her hemoglobin levels dropping rapidly, and her level of consciousness declining despite aggressive resuscitation efforts. This was a race against exsanguination, where every second of delay increased the risk of irreversible shock and death. The exploratory laparotomy revealed internal injuries that were worse than the diagnostic imaging had suggested. The liver laceration was extensive, involving multiple segments and major blood vessels. There was also damage to the spleen, small bowel, and retroperitoneal space that hadn't been visible on the emergency scans. Most trauma surgeons would have called for additional specialists and prepared for a surgery lasting several hours. Jennifer assessed the multiple injury sites and began working with systematic efficiency that left the surgical team struggling to keep pace. She was addressing multiple bleeding sources using simultaneously, techniques that seemed to defy conventional surgical training. Her approach was aggressive, yet precise, fast, yet methodical, achieving hemostasis while preserving organ function. The liver repair required advanced techniques, typically reserved for hepatobiliary specialists. Jennifer worked with instruments and methods that suggested extensive experience with complex liver trauma, stopping bleeding from vessels that most general surgeons wouldn't attempt to repair. Her suturing was perfect, her tissue handling gentle despite the urgent pace of the surgery. Packing removal, she announced as she prepared to assess her repairs for ongoing bleeding. The surgical packs came out clean, showing that her hemostasis was complete and the patient's blood loss had been controlled. The monitors confirmed what the surgical team was witnessing, vital signs that were steadily improving despite the severity of the initial trauma. Dr. Chen monitored the anesthesia with growing amazement at what she was observing. The Temp surgeon was not only saving lives that might have been lost, she was achieving surgical outcomes that exceeded what anyone had thought possible, given the extent of the patient's injuries. This wasn't just good trauma surgery. This was mastery at its highest level. As Jennifer completed the abdominal closure on her second trauma case, the emergency department notified the surgical team about the third accident victim, a 16-year-old high school student with severe head trauma, possible intracranial bleeding, and signs of increased intracranial pressure. The kind of case that typically required neurosurgical expertise and represented the most challenging emergency surgery the hospital faced. The patient's condition was deteriorating rapidly despite maximal medical management. His pupils were dilated and minimally reactive. His Glasgow Coma Scale was declining, and the CT scans showed a subdural hematoma that was causing dangerous brain compression. This was a case where minutes could mean the difference between recovery and permanent disability, between life and death. Dr. Reed found himself in an impossible situation. His neurosurgeon was in another surgery that couldn't be interrupted near ST. The neurosurgical backup was 45 minutes away, and the patient didn't have 45 minutes. He needed someone capable of performing emergency neurosurgery, and incredibly, the most skilled surgeon available was the Temp physician he'd dismissed as inexperienced just hours earlier. "Dr. Walsh," he said, as Jennifer emerged from OR1. "Do you have any experience with neurosurgical procedures?" Jennifer looked at the patient's scans, noting the classic signs of acute subdural hematoma with midline shift and brainstem compression. Emergency craniotomy, she said without hesitation, or 2, should be prepared for neurosurgical procedures. The surgical team exchanged glances that spoke of disbelief and growing respect. The temp surgeon was volunteering to perform brain surgery, the most technically demanding and high-risk procedure in all of medicine. But based on everything they'd witnessed throughout the night, she might actually be capable of saving a life that would otherwise be lost. The preparation for emergency neurosurgery required equipment and positioning that most general surgeons never encountered. Jennifer moved through the setup with methodical precision, adjusting the patient's head position, calibrating the cranial drill, and reviewing the imaging studies that would guide her approach to the life-threatening hematoma. Dr. Reed observed from the gallery, his hands clenched as he watched the temp surgeon prepare for a procedure that challenged even his most experienced neurosurgical colleagues. The 16-year-old patient's intracranial pressure was rising steadily, pushing against the limits of what medical management could control. Without immediate surgical intervention, herniation and death were inevitable. The first drill hole had to be placed with absolute precision. Too shallow, and the blood clot wouldn't be adequately drained. Too deep, and she risked penetrating brain tissue that could leave the teenager with permanent neurological damage. Jennifer positioned the perforator and began creating the initial burr hole. Her movements steady, despite the enormous pressure of operating on a child's brain. The bone dust cleared away to reveal the dura mater beneath, tense and discolored from the blood accumulation pressing against the brain surface. Jennifer carefully opened the protective membrane, immediately releasing dark, clotted blood that had been compressing vital brain structures. The patient's intracranial pressure dropped instantly, his pupils beginning to respond to light for the first time since the accident. But the evacuation revealed additional complications that the scans hadn't detected. There was active arterial bleeding from a torn middle meningeal artery, the source of the ongoing hemorrhage that would kill the patient if not controlled immediately. Jennifer identified the bleeding vessel and began the delicate process of achieving hemostasis without damaging surrounding brain tissue. Bipolar cautery, she requested, her voice maintaining the same calm authority she'd shown throughout the night. The surgical nurse handed her the instrument, watching as Jennifer carefully coagulated the torn artery while preserving the neural structures that controlled the teenager's motor function and speech. One wrong move could leave him paralyzed or unable to communicate. By dawn, 3 patients were recovering in intensive care, their lives saved by surgical precision that defied every assumption about temporary staff. Dr. Reed stood in his office, staring at operative reports that read like medical poetry. The substitute surgeon, he'd dismissed as desperate, had performed miracles that would be discussed in surgical conferences for years to come. But when he looked for Dr. Jennifer Walsh to offer her a permanent position, she was already gone, having slipped away as quietly as she'd arrived, leaving only a note thanking the staff for their professionalism. Some heroes work in shadows, transforming lives without seeking recognition, reminding us that extraordinary skill often hides behind ordinary appearances. The next time you encounter someone others have written off, remember that greatness doesn't always announce itself with credentials and fanfare.